for joining us for part one of our two-part webinar series, which is on spine care for personal injury patients. My name is Shadi Amin, and I'm the Director of Business Development for Pacific Spine and Orthopedics, and I'm the co-owner of Life and Health Chiropractic. We're very excited today because we have a phenomenal group of physicians and attorneys as our panelists. For both parts one and part two, just to let you know right now, part two is going to be following next week on Thursday, which is June 4th, and it's going to be at 2 p.m. So please keep that in mind and mark your calendars right now so you can see the rest of the docs at that point. We're going to have Dr. Kevin Trin on that day, pain management anesthesiology specialist, as well as Dr. Ali Najafi, neurosurgeon, and Eric Paris, attorney at law. What's different and exciting about this particular webinar today is that we are covering aspects of diagnosis for spinal conditions which you may not be all that familiar with. This will give you physicians the tools that you need to accurately diagnose and treat your patients and your attorneys to better represent your clients. With that being said, I'm going to introduce our lineup of doctors and attorneys for today's webinar. First up will be Dr. Daniel Clements. He's a chiropractor of Twins Chiropractic. He is a graduate of Southern California University of Health Sciences and also an associate faculty member. He is actually certified both in Canada as well as the United States to practice chiropractic. And they've got 4 locations in Orange County, being Placentia, Garden Grove, Costa Mesa, and Irvine. After that, it's going to be Dr. Jeffrey Kronk, who's a DCJD. He has been a chiropractor for over 30 years. He is with Spinal Kinetics. He is the Director of Education with a medical spinal ligament testing company, Spinal Kinetics, and board certified radiologist in kinetics. He's published studies in spinal ligament injury research as well. And he has developed the first online program for both attorneys as well as doctors for teaching spinal ligament injuries testing. After that, we're going to have Dr. Sana Khan. He is an MD PhD graduate of UCI and UCLA. He has been published numerous times and can boast also publishings with book authorship as well. He has developed numerous diagnostic centers which focus on more accurate diagnoses with upright MRIs as well as kinetic MRIs. He also has done numerous talks, which he was actually a part of right now prior to this webinar, as well as speaking engagements. After that, last but not least, is attorney John Reardon with Jorgensen and Solberg. He is also a practicing chiropractor, which right now basically he's doing more the attorney work with Jorgensen and Solberg. And he's actually been an early student of PI experts with Mark Student, as well as James Mathis. And he's got expert witness experience in 40+ depositions as well as 20+ trials. I am very, very excited to have all of you on with us, and I'm just going to double check and make sure over here that Dr. Clements is on with us currently right now. Is he on? If not, we're going to go ahead and start off with Dr. Jeffrey Kronk.
Great. Yeah.
Thank you so much, Dr. Kronk. I appreciate it.
Yep. So just let me know that you can see my screen.
Yes, you can.
Good. Doctors, first of all, Shadi, thank you very much for having me on this program. Doctors, what I'm going to do right now, we have 15 minutes to go over. What I'm going to show you is a really comprehensive spinal injury workup. And I'm going to show you, it ties a lot of things together. I'm going to move very quickly. I'm going to assume that you know most of what I'm saying, but I'm going to show it in maybe a way that you haven't seen it before. So I'm the CEO of a company called Spinal Kinetics. We're a nationwide radiology service that allows doctors to be able to have a test, excessive motion test, to be able to determine the severity and location of ligament injuries. Spinal ligament injuries are the #1 cause of chronic pain and disability in the market today. They are bar none the most expensive injuries in the market today. Before I start, I want to actually just go over a couple things. Injury, lesion, wound, derangement, impairment, all means the same thing. An impairment is a derangement of a body part. A derangement of a body part is an injury. A lesion is an injury. A wound is an injury. So you cannot injure the human body without deranging the parts. How we determine the severity and location of injuries is how badly deranged the parts are. Very, very simple stuff. Where the force comes from, if I have this fracture, derangement, wound, lesion, injury, and it comes from an auto accident, it's called an auto injury. If it comes from a sports-related injury, it's called a sports-related injury. If it comes from work-related injury, it's called a work-related injury. The force is different where you got the force, but the injury is the same. And that's the beautiful thing about spinal injury workups, is that they're super, super simple and they're super, super fast. And the consensus that I'm going to show you is amazing. So now we're going to focus not on any other part of the body than the spine. So in the spine, there are lesions, injuries, wounds, derangements, impairments that we need to be aware of right away. And there's really 3 of them. One of them is a fracture. I'm not going to touch on that today because we're going to take out the fracture workup. Fracture workups that don't have soft tissue damage are not very bad fractures. It's the soft tissues that are problematic. So what we're going to talk about is the 2 main soft tissue problematic injury, which is a ligament injury. Now, there's 2 things that you find on imaging as far as a biomarker. Biomarkers are things found on imaging that lead to a definitive diagnosis. You can't have this fracture, can't say a spine is fractured unless you have this imaging biomarker. You can't say that you have severe excessive motion problems unless you have an imaging biomarker. You can't say you have a disc herniation unless you have an imaging biomarker. So when we come down to spinal injuries, all 3 of those injuries can cause the need for really significant surgical interventions, but it starts off usually on the conservative side. So the workup I'm going to show you is good for the doctor of chiropractic, the doctor of physical therapy, the doctor of physiatry. It's good for the orthopedist, it's good for the neurologist, good for the neurosurgeon, good for the pain management guys. The workup that's done with the very first primary doctor should be the workup that follows all the way upstream, as I'll show you. So in chiropractic, and I'm going to focus on in chiropractic, when a doctor takes a set of x-rays, the national guidelines say that you're supposed to do a subluxation assessment. Spinal subluxation is any vertebra that's misaligned or mismoves that causes a motor, sensory, or pain problem, also causes nerve interference. It's the exact same thing as a spinal instability. So we're supposed to do a subluxation assessment, a spinal instability assessment, and we're supposed to determine the presence of any soft tissue injury, the presence of any fractures, and the presence of any bony pathologies, make an assessment for degenerative changes, and be able to count the number of vertebrae. That's in the national guidelines. What I'm going to show you is exactly how that works. Ligaments. Not going to give you much of an overview today other than there's 220 specialized ligaments that hold the spine together. 23 of those are discs. So out of these 220, 23 are discs, but we can't forget the other 197 that are non-disc. So there's a significant amount of ligaments here. 10 ligaments in all in a motion unit. So spinal ligament injuries, as I said, are the #1 cause of chronic pain and disability. I don't have time in 15 minutes to show you the off-the-chart statistics of the costs. Most doctors, when they see what the costs are kind of like, oh, well, why is my bill getting denied? If you really understand the cost to employers, cost to insurers, costs, they're quite significant. Now, if I go to Medscape, I'm a heavy objective guy. I like everything to be written, everything that I'm saying today be in guidelines. If I go to Medscape, these symptoms are what we see with a sprain injury. These symptoms, I would be willing to bet that there's not a symptom that you're dealing with a patient today that is outside of that symptom base. We know that these can cause ligament damage, causes a cervical instability. We know all the various things that can occur as a result of a spinal instability. So when we are dealing with injury workup, obviously the primary thing that drives all benefits is the diagnosis. How bad is the injury? Where is it? How bad is it? And that's the easiest part. A doctor actually does a consult. While he's listening to the consult, he's listening to these symptoms. He's writing down how bad is the neck pain? How bad are the headaches? What's the scale? He's doing pain questionnaires. He's monitoring all of this. And at the same time, he should be thinking about, hey, if I got damage in here, there's going to be derangement, because I can't have damage without derangement. And I can start to isolate based on what they're showing me exactly where this could be. I know as soon as I got headaches, upper cervical. As soon as I got pain and numbness going down in the arms, mid-cervical. So I go into an exam. Immediately I do motor checks and sensory checks. Remember, spinal instability is excessive motion or a problem with the soft tissue that's causing a motor, sensory, or a pain problem. I've already taken out the pain. I've already listed the pain. Excuse me. I've already listed the pain right there. Now I'm into motor and sensory. This leads me to levels, right? So to make that easier for you, if I have a C5 nerve motor challenge, I know it comes out the C4, C5 motion unit. So I want to know immediately, is that damaged? Do I have excessive motion here? Or do I have disc herniation here? Remember, there's 2 soft tissue imaging findings that can show and then verify how much damage I have. If I have neck flexion C1 and I'm up in this upper cervical, there's no disc up here, right? But I can certainly do an examination to determine how badly damaged the ligaments may be in this area. So this is very, very simple to do. I run a pinwheel here. I got a hyperparesthesia here. I know that that's C6. I know that C6 comes out between 5 and 6. So immediately I want to know how badly damaged is that area. I take x-rays immediately, good x-rays. When do I take them? You take them right away. You take them as long as the patient can actually bend and move their head forward and bend backwards. You can take a good set of x-rays. You have those x-rays sent out to board-certified medical radiologists to have accurate measurements of the intersegmental motion. You need that study. These are some of the most important findings, and they're seriously important enough that they should be done independent of the provider, because the provider is looked at as biased. You as treating providers are looked at as biased. Now, as soon as I get back the report, I look here, excessive motion, when I'm really good with it, if I have excessive motion in extension, it's highly predictive of a disc problem. So I know immediately, chances are good, I've got a disc problem here. Now, I also have a ratable level of ligament damage here, and I have severe ligament damage. I also have severe ligament damage noted here. So I've made my assessment. I know where my subluxations are. I know where my spinal instabilities are. I know the severity and location of those instabilities. I know how much soft tissue damage I have. I can rate it, I can grade it. And I've done everything that I need to do with this workup. Now, just to give you an idea, grade sprain. These findings right here are grade 3. These findings are grade 2. These findings are grade 3. Now, if you don't understand this in 15 minutes, I don't have a chance to completely explain it to you, but it's very, very simple stuff. And every doctor should understand it. Severe instability here, moderate spinal instability here, severe spinal instability here. Now, if I'm a chiropractor and I want to go to my treatment guidelines, I'm right there on my treatment guidelines, and I have a grade or a severity that allows me to treat for a certain duration of time. Now I'm guideline compliant. I also have, look, these findings right here. If I've got a person who's in sports, I got a sports activity modification finding. I'll show you in a second. I also have a surgical pre-authorization for spinal fusion findings right here. And this also triggers an impairment rating. So this alteration motion segment integrity finding comes right off the USC Southern California website, is a absolute contraindication to putting that player back into that sports activity if you thought they could injure their neck. That same finding generates an impairment. That same finding triggers surgical guidelines to actually say, from flexion extension radiographs, we've got the amount of excessive motion that would pre-authorize a spinal fusion surgery. This is what that spinal fusion surgery might look like. Now, It also does this for me. It shows definitively why the patient has headaches. It shows definitively why the patient has neck pain, numbness into the arms, or numbness into the arms. Now, I'm only at day 3 to day 5 with this patient. It also tells me that I have a really high chance that this patient also has a disc complication. That's everything that, now that exam and that exam procedure for doctors that are really grooved in with it should take you about 10 minutes. That is not a long procedure to do, but look at what it ties into. Now, if I thought that the person I sent out and they now have a disc herniation without excessive motion is much, it's much easier to treat than disc herniation without excessive motion. So I've just done a very simple workup. I followed completely compliant guidelines. And now I know exactly the damage the patient's going to have. So if I'm a chiropractor, I'm going to put them through my chiropractic treatment protocols. If I have physical therapy, I'm going to put them through my physical therapeutics. I'm guideline driven to do all of it now. If it fails, then I'm looking at injections. I'm going to pain management. If that fails, I'm going to the further pain management of ablation. If that fails, I'm going to the surgeon. Now, that simple workup should be done on every single patient because it goes upstream and it communicates totally to everyone involved exactly what that patient has, and it ties in the severity of all of the consensus and documentation that says that these injuries are incredibly serious. And they need a doctor that actually understands that so that you can get great treatment results, because everybody's trying to get great treatment results. The chiropractor is trying to not have it go to the surgeon. The pain management specialist is trying to not have it go to the surgeon. Everybody's trying to get results. Results start with understanding the injury itself. And Shadi, we have 15 minutes. I'm at 13 minutes, so I'm going to hand off some time. I don't know who you, I know that when we did the lineup, it was to Dr. Khan, who is I'm a huge fan of from a distance, but I'll let you as the director tell me, is that where I'm going? We can't hear you, Shadi.
I apologize, I was still on mute. I was trying to find out when Dr. Clemens was going to get on again. It seems like we've got a little bit of a technical difficulty. So Dr. Khan, what do you think if we just move on with you currently right now and just take this opportunity? If you got any questions, please go ahead and type that out in the Q&A section. We are going to take 15 minutes at the end of this webinar and answer all of your questions one by one, okay? Thank you so much. Thanks, Doc.
Yep, you're welcome.
Can you guys hear me?
Oh, you are on now. Perfect. There we go. Dr. Clemens actually just came on, Dr. Khan.
Yes, I did. Excellent. All right. Should I go on and then Dr. Clemens come? Okay, good. So
absolutely. Continue,
Doc.
Doc.
Let me see if I can beat Dr. Kronk's time.
There you go.
Okay, so basically, so my name is Sana Khan. I'm a radiologist, and I own imaging centers called Expert MRI in California and called Altus Healthcare in Texas. So just to give you a quick, I really enjoyed your talk, Dr. Kronk, and I think hopefully I'll try to do justice to it here. So I have all different kinds of machines. So I have these traditional high field 1.5 and now 3.0 Tesla units. I have the standard open MRIs, and then I have these latest design change in MRIs called the vertical or the upright MRIs. And these MRs are basically, the design is interesting because the magnets are on the side and they're vertical. So there's nothing in front of the patient. So this actually allows us to do different types of positioning on the patient. Patient can be sitting, standing, flexion, extension. If the patient complains of pain in the laying down position, we will lay them down. So the idea really isn't, whether it's standing or sitting or whatever, it's just what position is the patient complaining of their pain. And I was speaking to a neurosurgeon from USC this morning. He was asking me more about this, and he said, can you just tell me, like, what's the great advantage of this? And I said, symptom-specific imaging, basically, because whenever you're examining a patient as a chiropractor, as an ortho, you don't lay the patient down in one position and just poke at them. You're actually, bending the knee, twisting and saying, where does it hurt? So you can clinically correlate what's going on with the patient. My preference, just in terms of MRI-wise, when I do brain MRs, I really like the high field. When I do body imaging, which is chest and abdomen, I really like the 1.5. So the 3 T's for the brain, 1.5 for body, and the 0.6 Tesla uprights for musculoskeletal. And I'll show you why as we go along. So as Dr. Cronk was mentioning, right, there's so many ligaments that are surrounding the spine. So the spine is a really well-protected structure. Why? Because there's a very, very important structure going right through this canal. It's called the spinal cord. So it's really, the spine is designed to protect the spinal cord and the nerves that are coming out and going out to the body or going from the body. Now, one thing we all know is, just intuitively speaking, that gravity matters. If not, then we would all float away to space, I suppose. But it really matters in terms of your body as well, right? So if you look at the disc itself, the pressure within the disc space actually varies with weight bearing. And we've known this for decades now. Numerous papers have been published on it. But just to give you an idea, the least amount of pressure on the disc is the patient laying down. And the greatest amount of pressure actually is not in standing position. Often people think it's in standing. It's actually in the sitting position where you have the most pressure on the disc in the spine. And it's a pretty significant difference. You're talking about, lifting a 25-pound dumbbell compared to lifting a 275-pound dumbbell. Pretty different, right? So, and also it has its effects on the discs itself. So just keeping that in mind, why does symptom-specific matter? Why does position really matter? Well, so here's a case. I'll give you several examples, but here's a case in which this patient literally had 3 normal MRIs prior to coming to us. And when he came to us, so the story is interesting because the chief complaint was, I can't lift my 3-year-old son. Because every time he would lift his kid, his neck would go back and he would feel like dropping the child, right? So say, let's put the patient in that position and do the scan. And we did, and here's your chin and the head tilted up. But look what you have here. You have 3 large disc herniations, multiple levels spinal cord compression, completely normal. We put the patient back in your traditional view, did the scan, 10 minutes apart, completely looking normal. The discs are well hydrated, no disc herniations, spinal cord looks fine, whereas the patient had a lot of problems. And this is because a disc, particularly a hydrated disc, actually is quite mobile. It can come in and out. So, when you have the annulus tears, and by the way, these are different types of disc herniations: protrusion, extrusion, and sequestration. But the disc can actually move in and out, as demonstrated by this case. So it's really important. This patient actually had tears in his eyes afterwards, and they were wondering, like, why are you crying? And he said, even my own family had stopped believing me. And it was I think it was a PI case, so even the judges and the juries and all that stuff, right? They really believed the MRI more than the patient often. There is definitely, in terms of impairment ratings, that's Dr. Cronk was talking about, that there's a difference in the impairment ratings, obviously, when you have pathology versus when you don't have anything. Here, it's an interesting slide because, the AMA guides, this is from the 5th edition, actually note something interesting. It says that the dominant motions at both the lower cervical and the entire lumbar spine, where most clinical pathology occurs, are flexion and extension. So let's read it backwards a little bit. If we don't do flexion and extension imaging on our patients, we're actually missing most of the clinical pathology according to the American Medical Association. So, every patient really, as long as they can tolerate it, should have a range of motion X-ray and possibly MRI if that's needed. Give you an example of what that really means here. Here's a recumbent scan, right? This patient was sitting when we did, laying down when we did this scan. And you know what? I could kind of tell you there's a little bit of anterior listhesis here. If you got too fast, I might have missed it potentially, but we can see that it's there, but nothing to really write home about in terms of the impairment rating work, right? But there is some. Well, this same patient, 10 minutes apart, okay? Standing, flexion, look at this, right? here you have a 5.1 millimeter anterolacesis and lands the patient into category 4, DRE category 4 from the AMA guides. Patient's impairment rating goes from 5 to 8% to 20-23% solely on the imaging difference. But this instability, spinal instability from spinal ligamentous damage, would have been missed had we just done the patient in a single position laying down scenario. This was really a great case because we were kind of like the AME on the case. So here the story was interesting because this is a workers' comp case, and the patient went to the QME. He was there because we had severe, pain, but there was litigation on the case, and the fact that the two sides were fighting over him because the MRI did not show something called Chiropractic syndrome. Well, the QME confirmed clinically the patient had Chiropractic syndrome, but the argument in the court was the defense was still arguing that, hey, look, there's no evidence of the cauda equina being compressed or injured. So here you can see on the recumbent scan, the alignment looks pretty good. You have a couple of dark discs here, and you have a disc protrusion in the back, but you don't really have anything hitting the cord or the lower part of the cord. So, so the applicant attorney was saying, look, you examine the patient laying down. So the judge basically said, just go get the weight-bearing MRI done if that's what you want. It's going to cost $700 or whatever. Just get it done. So the patient came to us, did the MRI weight-bearing, and you do not have to be a radiologist to see the instability at this level, compression of the cauda equina. And again, we laid the patient down because we do a lot of research in our place. We do free MRIs lots of times, and the instability reduced back to its normal place, right? So it's really interesting. These are 10 minutes apart. The part of the problem is, as chiropractors too, that when you guys are doing these, I mean, you really need to know that this exists in the patient before you start adjusting the patient. Because if you get back a report that says the alignment looks good, and yes, there's a couple of degenerative disc disease, you might start, adjusting the patient with some force. Here, you want to be very, very careful about this, right? Just so you know, the patient's rating on this case went from a 13% to a 78% WPI. The offer went from $18,000 to $256,000. But the issue wasn't the offer of the dollar amount, more than the fact that the patient got future medical care, which means that the patient can take care of the problem for, in their life, rather than, having $18,000 and being stuck for the rest of their lives. This is kind of an interesting scan because, what I wanted to show you was, so this is a study that was done out of Oxford, and it showed the lesser of the amounts of missed pathology. Some studies talk about 65%, some say 67%. This one said 52% of the time you actually miss pathology on patients if you do not do them symptom specific. Every single time, one position, you're going to miss the injury more than half the time. And this actually is an interesting scan because what kind of demonstrates to you that when the patient is laying down, you can see, the alignment looks pretty reasonable. You don't see any of the compression of the cord. But when the patient when we do the MRI sitting down with weight bearing, you can see reversal curvature, right? And you can see that it's interesting that it's the cord that moves forward. With gravity, the cord actually goes against the posterior elements. When you have the patient sitting or standing, the cord moves forward, and it's actually the cord hitting the disc, not the disc hitting the cord. So, but of course, that still causes the pain and the damage and the irritability. But it's interesting when you change positions, how the spinal cord actually also changes position. I'm sure you've all heard of failed back surgery syndrome. And as Dr. Cronk was pointing out, you got to start off as you're doing the analysis with the clinical examinations and then the imaging before you get into the pain management and into the surgeries. Because here, if the surgeon had gotten, here's an MRI that was done, and the patient, you can see a very large disc herniation at 2, 3, 4, at 5, 6, and of course spinal stenosis, compression of the cord. Now, had they done surgery on this patient at this level, they would have fixed the level likely, but the patient would have come back with failed back surgery syndrome. Why? Because when we did this patient upright extension, you can see that there is a large disc herniation right above this level as well. So it would be best if the surgeons actually went in and fixed both levels rather than just one, because with one, patient comes back with failed back surgery, Yeah, 6 months of therapy, it didn't help. You go back and you do this exam and you see this problem. Well, here we go, right? You have to do the surgery again. Scar tissue, higher infection chances to get sued for malpractice and all that stuff are pretty significant. So last but not least, I want to show you something really interesting talking about ligaments. And you know, as we all know, Shadi, do you know what when I say how much the head weighs, what's the answer typically? You're on mute still. How many pounds?
12 pounds, like a bowling ball.
Oh, good. Oh, okay, good. That's okay. So it's 10 to 12 pounds, typically the head. So I always say that it's a bowling ball. So it's sitting on a stick, which is the vertebral column. You have this bowling ball that when you have an accident or fall or whatever, you know, this bowling ball goes in all different directions. That's the reason you get the damage to the discs and the ligaments and everything else, because you have this stick that's trying to hold up this bowling ball and it's going all different directions in these kind of accidents. Well, this bowling ball up here is being held to the stick by these 5 ligaments called the craniocervical ligaments. The primary of those are the alar ligaments that are at the craniocervical junction, and the transverse ligaments, right? The holding C1 from C1 to C1. So listen, guys, here's the question I'm going to ask you, and this is tricky, okay? Dr. Kronk, on every MRI, that cervical spine MRI, I want you to, from here on forward, look at the level they start and look where they end. And what you will see is that the cervical spine MRI, typically standard, starts off at C2, middle of C2, down to C7, T1, okay? The question is, why? And I'll tell you the answer maybe someday, but it's because early on in our work, when I have whiplash injuries, orthopedic surgeons actually came down to the basement. That's where we live as radiologists, and would tell us to start at C2 and go below. So that became standard, because nobody in the right mind is going to let an orthopedic surgeon go into this brainstem area where these ligaments are sitting. But do you know that in whiplash injuries, 57% of the time, the injury is occurring at the craniocervical junction ligaments? And that's crazy, because if you're not scanning, if your centers are not scanning above the C2 level, you are missing injury that occurs up here 57% of the time. Now, chiropractors need to know this, because in order for you to treat the patient and do your adjustments, it's really important that you know to what extent, if there is injury, to what extent does it exist, okay? And then you treat accordingly. But, you know, and again, I don't want to belabor this too much. So the way we see injuries here, and again, these are MRIs, and I don't expect you guys to learn all the anatomy. Just so you know, the alar ligaments are here where I'm pointing with the arrows, dark, that's normal. What we see with the injured ligaments is this brightness within the ligaments, and that's blood. So we can actually see that and appreciate it when we scan with MRIs up there. And if you don't see the blood, and maybe it's later on in the scan, we can see the looseness by doing some measurements. So the odontoid peg actually deviates to the opposite side of the injury. So what happens is whenever the injury loosens the ligament, the odontoid actually can go to the other side. And these measurements are pretty easy to do. I'm sure that Dr. Kronk will do those on his studies as well. But this is the other crazy part about this. If you scan a C2 and go down in patients like this, you would miss the fracture right at the tip, at the odontoid tip. We would have missed the focal myelomalacia, and we would have gotten from here down, potentially have called this patient normal in terms of the spinal cord. I know there's problems down here, but you really want to be able to report these other problems, because what happens is they can actually compress the brainstem, the medulla oblongata, where you have all the autonomic functions are there, breathing, heart, swallowing. So it's very important. So in our practice, we have made it a standard. Anytime somebody orders a cervical spine MRI, we're going to start at the craniocervical junction and go down from there. That needs to be the standard of care as far as I'm concerned for cervical spine MRIs and for ligament damage. You know, last but not least, you know, our patients, if you look at these studies, and by the way, my slides are available, so I can give it to you, Shadi. Anybody who wants it, you guys, you're welcome to have them.
Fantastic.
Yeah, so look at this long-term consequence, right? Even after 15 years, this is all reviewed papers published. The authors documented that 70% of patients continue to complain of symptoms referable to their original accident. So we really need to diagnose the patients properly. We need to treat them properly. We don't want somebody living with this kind of pain, you know, neck pain, stiffness, shoulder stiffness, headaches, tinnitus, dizziness, right? For decades to come in their lives. That's it. That's my part. I'm done. And oh, Dr. Kronk, I lost you by 1 minute.
You're perfect.
Sorry. All right, Shadi, back to you.
Thank you so much. I appreciate it. Again, we've got a couple of questions which we're going to address at the end of the webinar, so we will get back to you. We are seeing it. So Dr. Clements, over to you now. Thank you so much, Dr. Kronk.
You're welcome.
All right. Let me just get my PowerPoint on here. All right, so I'm Dr. David Clements, and I have an identical twin brother. As you can see, we're twins chiropractic, and we see a lot of PI. And one of the things that I wanted to overview is a lot of chiropractors who see PI kind of miss the boat on the importance of what they need to do to manage the case. An overview of chiropractic is basically, if you don't have a knowledge of chiropractic, patients are going to come in, get their joints adjusted. We're the primary care practitioners, which means that patients see us first. Most people don't realize that when a car accident happens, they typically won't go to the ER. They will go to a chiropractor. Sometimes they'll go to an MD, but that's where the chiropractor has to be in the front of the driver's seat with case management, which I'll talk in a second. But we're the first people they see, the first doctor. And what we do is, it's conservative care. So what we're trying to eliminate is most of the symptoms the patient is coming in with. And so that's going to overview what chiropractic does for personal injury. So when a typical patient comes in, what we want to do is we need to do a thorough history. And so what that's going to consist of is doing a neurological exam, orthopedic exam, taking x-rays, including flexion extensions, checking for instability. But this exam is very important. Most chiropractors miss out on this because they skip through a lot of the history and documenting a lot of the findings that they could be documenting, but they're just skipping over. And so when we see patients, we need to kind of slow her down when it comes to a personal injury so that we can list all the different diagnoses that come in or that they have. And so the treatment after that is going to be chiropractic adjustments, traction, therapeutic exercises, and that's all dependent on the patient's needs. And then typically, one thing that I forgot is we want to send out, if the patient needs it, an MRI as soon as possible, as early as possible. And this is very important, which I'll touch on in a few more slides. But the overview is the exam, the treatment, and then if the patient's not getting better, typically we try and get all the symptoms gone, but that's not always the case for injured patients, and pain management referral is needed at that time. And so without sending the patient to a pain management specialist or an orthopedic or hand specialist, depending on what their injury is, the chiropractor is doing a disservice to that patient. And so that's the importance is as a chiropractor, we need, when we have an injured patient that's legitimately injured and we see the pictures of the property damage, we have to take a step back and make sure that this patient gets everything that is needed so that they can get healthy. And if they don't get healthy, that we have it all documented of their injuries. So the most important thing is diagnosis. So whiplash, the body's getting whipped around in the car. And so depending on the mechanism of injury, a lot of chiropractors, what they do is just put sprain strain. That's the whiplash diagnosis. That's the minor diagnosis in a personal injury case. Now, some patients may just have that certain diagnosis because it's a minor whiplash case, but major whiplash cases, there's usually a major diagnosis, such as a disc herniation, ligament damage where it's ripped. So it's, instead of a sprain, we have grades of vertebral instability. And so without having that major diagnosis, the chiropractor's already made the case for that patient going downhill. And so the attorney is going to have to fight their way up. So we make sure that that MRI that we do allows us to find the disc herniation that may be asymptomatic at the time, and then change the treatment plan if needed. Also, besides the spinal injuries, traumatic brain injuries, TBI, that's another thing that you cannot miss as a chiropractor. So if a patient says, hey, I had a headache, the worst headache I've ever had, that's a huge red flag that we need to do, either get them to do we send them straight to the ER immediately if they say something like that. Also, they're filling out concussion forms by the CDC. And so the reason why we do that is because when we get deposed as a chiropractor by an attorney and they said, well, how do you know that they got a concussion? And so the forms that we use from the CDC, the Center of Disease Control, it's not us diagnosing it, it's the Center of Disease Control diagnosing it. So it really puts the plaintiff attorneys kind of stepping back. Also, we're also trying to not miss any fractures, and then different diagnoses, PCL tears in the knee, or just constant headaches that are after the accident. So diagnosing is one of the things we want to list all that's there. We don't want to miss anything that the patient has stated. Okay, so reason for an MRI. A lot of chiropractors will send out an MRI 6 to 8 weeks after conservative treatment. I feel like this needs to be done earlier, because one of the things that we do in our office is we don't want to be doing guesswork, and we need to have that MRI kind of guiding where our treatment's going to be. And so we need the MRI as early as possible so that we can see if there's any underlying conditions, or else we're doing the patient a disservice. Okay, so patients will benefit more with the MRI to clear them of the injury, so that's great. So we can, but if they have an injury and we did not take an MRI, and they get to the point where at 6 to 8 weeks, they're out of pain, now they're less inclined to get that MRI because they don't understand why they would need it. And that also puts the chiropractor in a funny situation, because now they're trying to persuade the patient to get an MRI, where now the integrity of the chiropractor is kind of being questioned. And that's the main thing we never want to do. We want to make sure that that MRI is referred when the patient has pain, has symptoms, so that we can definitely tell that when we get the results back that those symptoms are correspond to what we see in the MRI. Secondly, what we've noticed, we've had a few times in our office where a patient gets into a car accident and they don't get the MRI, or in this situation, the patient got the MRI and then they got into a second car accident. And most of the time, attorneys have a difficult time because the adjuster will say the second car accident caused all the symptoms, and now they're off the hook, and another insurance company has to cover it, and then it's a back and forth game. If the MRI for the first car accident is done early enough, we have record. And attorneys love the fact that, hey, the second accident happened, it wasn't as big of an injury. The first one was, but now we have a detailed report of what the first accident actually caused. And then, because most of the time that doesn't happen, but if you have that MRI done soon, you've covered it, because we have had multiple occasions where that's covered us, or covered and helped the patient get the recovery they needed because they had that MRI done soon. The biggest part that we have in our office is we train our chiropractors to case manage, because if the chiropractor is not directing that patient in the right direction of all the treatment that they need. And I'm talking about patients that need the care, not the patients that get an offender better and that the injuries are small. I'm talking about patients that need care, they're not getting better, and that we're directing it in the right way. So patients need to know the severity of their injuries. So we need to teach them as chiropractors what the impacts are if the patient doesn't get the treatment they need. And so with that education that we give the patient, they're a lot more consistent in making their appointments, which is a huge issue with a lot of chiropractors, because the patients come in, they don't understand that they need to come in 3 times a week. They don't understand that the adjuster is never going to see them, and that the only way they can tell the adjuster that they're in pain is by making their appointments. Because a patient coming in 1 time a week or 1 time every 2 weeks is not a patient that is in severe pain. A patient will come in 3 times a week if they're in severe pain and follow the treatment protocols. And then also for case managing, sending the MRIs and following up the fact that they got the MRI. Okay, so our staff in our office, we have 4 girls in our PI department that we go through each patient, and every week goes by, we make sure that they've made their appointments, and if they haven't, we call them with severe urgency to you need to get that MRI. If you're not getting the MRI, you're gonna be injured. And then secondly, making sure that if the chiropractic, we hope gets their pain totally gone, but in some cases they don't. Chiropractor's not working. We need to make a decision when we change their treatment plan. And so that's when we send them to a pain management doctor to evaluate them for a second opinion as a specialist. And then they can help direct the treatment at that time. And so we co-manage, and they give pain injections, epidurals, whatever they recommend for that specific patient, and then send them back to us, or we try acupuncture or a different type of treatment. And so that's makes the cases a lot stronger, and helps the attorneys a lot. Preventing gaps in care, this has got to be every attorney's nightmare. This is where we've really have an expertise in. We make sure that each patient knows that they cannot have a gap in care. Everyone knows that if you have a gap in care, you've just told everyone that you're out of pain, and then when you come back, that pain that you've coming back for is not from the accident. And so that's where we educate our patients, you're going to be getting text messages, you're going to be getting them every appointment 2 hours before, 30 minutes before, so that you do not miss your appointments. Okay, for 2 reasons. It's going to get you better faster, but it's also going to tell the adjuster that you mean that you're basically communicating that you're in pain and you want to get out of it. And then lastly, reports. Our reports detail what major impacts that the patient has had from the accident. So activities of daily living is, you could list off 40 different things, and adjusters will look through that. We list off the major impacts that specific patient is going to be impacted by. If it's, fighting at home and it's now they have marriage issues, that's something that we put in the reports because that impacted the patient because of the accident, because they had pain, they can't work, and now there's family trouble. And so those are the things that we put in the reports so that the attorneys can look at and use this for their case, because it's something that's very specific to the patient. Okay, because you could say anytime, oh, they couldn't do household chores. Well, that's that's what everyone writes. And so we do it specific for the patient. So that's where we, as chiropractors, when we manage personal injury cases, we make sure that from the start to finish, we have everything in order. We let the patient know that the journey of what their care is going to look like, so there's nothing left to question. If we get them better, great, we can discharge them, but if we don't, we send them to the right way, or to the right specialist. So that's the last slide.
Thank you. Thanks so much, Dr. Clemens. And again, we'll get to your questions in a little bit. I know some of you have already gotten it answered. Now we've got from Jorgensen and Solberg, John Reardon.
All right.
Thank
Dr.
you,
Clemens,
John.
can you guys hear me okay?
Yes.
Yes.
All right.
Yeah.
Dr. Clemens, you absolutely nailed it. You truly, you nailed it. What we're looking for from chiropractors, and so you did great. Let me pull up my screen real quick. Okay, so just quick introduction. I'm Dr. John Reardon. Got some history there, but this might sum it up a little better. All right, so in my history, I've literally been on all sides of this whole PI thing. I was a provider, just like most of you out there listening, for 20 years. I served as an expert witness, 40 depositions, 20 trials. I've taken this information into court and supported it for the judge and jury, and done a great job with that. I manage PI cases in the attorney's office, so I kind of bridge the gap between the attorney, the chiropractor, the adjuster. Now I'm just taking the role of the attorney, and I couldn't be happier about it. The goal of the day, though, is I want to show you how we can take all this information and truly make it valuable. So let's jump on it. I'm starting with this slide because, docs, I want you to hear that out of all this PI thing, your role as the chiropractor is the most important role out there. You, as Dr. Clemens was saying, the patient goes to you, and then from your care, from your oversight, their entire case is directed. And the things you do or the things you don't do determines the value of the claim. So you're important, all right? Now here's something I didn't quite understand when I was a young chiropractor. Every claim has a timeline, a PI claim timeline. From the moment they're injured, the very second they're injured, until the moment that they sign the release, which releases all liability, any future injuries don't have any value, everything starts and ends right there. As soon as they sign the release, if the injury wasn't diagnosed, it wasn't worked up properly, it doesn't matter. The window's gone. So this window is where we operate. And docs, you're the quarterback. So we've always talked about the science, art, and philosophy of chiropractic. Let me put a little spin on it. Let me talk about the philosophy of personal injury chiropractic. And I'll start with myself here. I applied a philosophy to personal injury patients that was wrong. Looking back, I made some mistakes. And I was really focused so much on getting people out of pain, documenting that chiropractic worked, that honestly, I missed so many injuries, and I did my patients a disservice. So that's one thing I want to share with you guys. This information can help us be better doctors, help our people. So never forget, a PI patient is a med legal patient. They have to be treated differently. So your first job as a chiropractor taking care of PI patients, your first job is to document and prove the full extent of the injuries. Your documentation, your oversight will your second job, so remember, we have that small window of time. We have to do all the work.
John, your sound is going in and out. I'm not quite sure if Dr. Khan, can you hear the sound going in and out as well?
Right.
Okay.
So I think something's happening with your microphone. Maybe it's kind of getting covered. Just wanted to let you know. Thank you.
Okay, thank you.
But your slides are great, so I'm actually reading them off there too, so that's great.
All right, cool. If the sound happens again, like wave at me or something.
Okay.
I'll try to correct it. Can you hear me okay now?
Yep.
So this is cool, and I didn't know this early on as a chiropractor, and a lot of it I didn't know until more recently. Here's how a PI claim works. First, the important things is a PI claim is a bodily injury claim. Keep that in mind, a bodily injury claim. 99.7% of them are resolved through settlement. We're always afraid of court. rarely happens. So right now, let's focus on settlement. From the settlement, your bill gets paid. Bigger settlement, more money to you, right? More money to pay the bill. So here's this. At the end of the day, we have a settlement. How do we get the settlement? Well, that happens through negotiation. The role of the attorney is to negotiate with the adjuster and work our magic and then find a number where the client will be happy to sign the release. Well, how do we value a claim? Here's the truth of it. A claim is valued by an adjuster, right? The adjuster enters data into a claim valuation software. Generally, we'll call it Colossus. The Colossus will spit back a value range. This is the key that a lot of people don't understand. At that moment, the adjuster is lumped into settling that claim in that range. Now, there's exceptions to that, but his job performance, his job itself, all hinge upon him being able to do his job within the parameters given by Colossus. So we send a demand over that has all the information. Within that demand are your medical records, your exam sheets, your SOAP notes, any kind of medical specialists, all the diagnostic work that's done. When we titrate all that data down, value drivers. Probably most of you have heard of a value driver. What is it? It's important, all right? Because from the value drivers, the attorney has to echo those value drivers in his demand letter, which then goes off to the adjuster, and the adjuster enters those value drivers into the software, which ends up with a value. I didn't make this information up. I'm a student of this myself. James Mathis and Dr. Aaron Deshaw, who's also an attorney, they're the lead guys on this. They've put the time in. They've been involved in lawsuits, discovery. They've written books about it. I recommend anything that they write, buy it. If there's a seminar they're going to be involved in, go see it. Their information is. Today we're going to cover the top 5 value drivers. Drive the value in Colossus. Truthfully, I'm going to cover one. I have 1 minute left within our hour. So I'm going to cover one. And the most important one that is a portal for all the value inside of a claim, is the injury diagnosis. This is what ties in so well with Dr. Kronk's Ligament study, Dr. Sana Khan's expert MRI. These are the building blocks of the whole claim. So the first thing, I'm going to give you 3 keys today. First thing you can do to increase your settlement value is to diagnose it. Let's talk about that. Remember, it's a bodily injury claim, so we're not diagnosing symptoms. Every injury has an ICD-10. Within that injury code, Colossus builds in what the relative value of treatment, future care, and the pain and suffering. Example is if we're talking about a very large disc extrusion with radiculopathy or ligament instability, AOMSI, that's big. That's heavy within Colossus. We're talking about a sprain strain. Dr. Clements was saying, that's very small. That if there's a scale, adjusters don't put much value on sprain strain. Colossus does put value on larger diagnosis codes. So as the docs were talking about, when we're diagnosing an injury, here's an example of a lady involved in a car accident. If she walked into your office, you can't just say cervical whiplash. It doesn't tell the story. There's no value within Colossus for cervical whiplash. None really. We need to diagnose, Dr. Kronk, you're like this, diagnose the derangement of the tissue. We need to diagnose the injury for every component of the spinal anatomy that's been involved. That is bone, disc, ligament. So when you look at it, you compare the 2 images, or 3 images, we can talk about a neck, or we can talk about ligaments, discs, nerves. Colossus likes more granular diagnosis. So this is a quick cheat sheet you can use. For every component of the spine, there's an associated objective diagnostic test you can do. And then you end up with a pathology. That pathology has an ICD-10 code. And then as we'll talk about a little bit later, from that, you then make sure the patient gets to the right specialist, because you want the specialist to echo that diagnosis and talk about the other 5 So diagnostic testing has to be done. We refer to the MD specialist so that they can hit the other.
Who's fading in and out, John? If you can maybe come closer to the screen.
Okay, thank you.
There you go.
All right. So after you diagnose them, you want the specialist. Within Colossus, chiropractor can definitely give a diagnosis.
Now we lost your sound.
Juan, we lost your sound altogether. I'm not sure what's going on with the mic.
I wish I knew American Sign Language. Okay, well, I'll just kind of move forward. I know we're kind of running out of time. So can you hear me now?
Yes.
Yes.
Okay. So a strong diagnosis would work like this. You list your injuries first. The most severe at the very top of the list. Concussion, obviously, the brain injury is the top. You move down from there. You go into your discs, your ligaments, but you use the proper code. Maybe you Google it or get a good reference manual. You want to find codes that truly explain the injury, such as disc herniation with radiculopathy at the C5, C6 level. Like, find the right code. This Colossus is looking for. Then following that, you want to touch on radiculopathies. And then interesting with whiplash, the two codes of muscle guarding and loss of cervical lordosis carry surprisingly high value. So if they're present, always record those within your top 10 lists. Let's talk about the second. So I tell all my doctors that we're working with, after you diagnose the injuries, focus on diagnosing the injuries. Take flexion extension x-rays on every trauma patient. Dr. Kronk has already said that. Dr. Clement said that. This is why. First, we can get amazing diagnostic code. Second, if I'm an adjuster or an attorney that doesn't quite understand all this stuff yet, look at that image. It's obvious, right? And not just to us. We see that, but a lawyer and an adjuster will see it too. They'll be afraid to take this case to trial because we're going to put this image in. A picture's worth 1,000 words. And that's what goes back to my mantra in my office, imaging rules. Is that an image? Does it really exist? With an image, you can't deny it. And if you notice the brain image up here, we did the scan, and after the scan, I sent the image to the adjuster, quick note, got the policy limits with it. It's irrefutable. It's demonstrable, as some people call it. Dr. Cohn has talked about the flexion extension MRIs. If we believe there's a disc pathology, we make sure that that patient has a weight-bearing positional MRI. Because the images are so amazing, but if you look at the radiology report, you see that they find things.
John, we lost you a little bit.
They make, expert MRI makes beautiful reports. They find things that a normal incumbent or MRI would not find. So if you, in your area, try to find a weight bearing, sure. So let's put it all together. With my doctors, I try to train them. Focus on looking for injuries, diagnose it early. As Dr. Clement said, do it soon. So here's a quick spreadsheet or graphic here. Within the first day, you're doing a good exam, you're taking those x-rays. Do flexion extensions and send them out that day. Dr. Kronk's group gets the reports back within 3 to 5 days at the most. So within your first week, you know if there's instability. If there is, promote that patient in or off to an MRI. Get the MRI, get that diagnosis, what's happening in this. It'll help you treat better. It'll help you understand the full pathology that's happening. And then as soon as we get the MRI back, if we find significant spinal injury, have a specialist review that case. Have them echo your diagnosis. Work with you. You'll notice that along this whole pathway, you're still caring for the patient. You're still giving them what they need to get better. But down here, we're proving their injuries. You're supporting their PI case. So keep that in mind. I'm almost done actually with my presentation. So there's our players, right? Got to build a team around you. So my final thoughts. All right, John's final thoughts here. So I found as a provider, and now on this side as well, if we look for the injuries, you're going to be surprised what you find. Start doing the ligament studies, the TBI, learn about that. How many TBI patients went through my practice? I never diagnosed them. So start looking for these injuries. You're going to be surprised. When you do, the cases you're involved in settle for much higher amounts because you're proving the true injury, the true pathology. Lastly, I have a lot of chiropractors asking, how do I get more work? How do I get more PI work? Well, start doing this stuff. You know, I wouldn't send my cases to somebody who wasn't. You know what I mean? So I think that's a good thing about it. So there's my contact information. If anybody has any more questions, I know I'm off the mic here in a second. As we're concluding, I believe next week, Shadi, you have 2 of your specialists coming on, and it's Dr. Trin and Dr. Najafi. Both of those, they're great doctors. They're very personable. What I love about them is they understand not just that first piece of the 5 value drivers, they understand the other ones too. So when your patient goes to them, you're going to help capture the full value. Thank you.
Thank you so much. Absolutely. Thanks so much for that. John, that was fantastic. We've got some questions over here. I know the first question, it says, would you recommend an AP open mouth with lateral flexion for all PI cases for atlantoaxial ligament injury? Dr. Cronk, I believe you're going to be answering this.
Yeah, absolutely, 100%. If you thought that the patient had ligament damage there and it was consistent with the type of symptomology that you would see with an upper cervical ligament injury, absolutely 100%, you want to do it every time.
Yep.
Fantastic. Another question to you again, Dr. Cronk. Where can you get the evaluation that Dr. Cronk was using? I believe this is like for the forms, maybe.
The form, no one can have that form. That's a personal form that only I have. However, I'll send it to Shadi, and Shadi can get it out to anybody that wants it. I'll send it over to you, and you can get it out to anybody that wants it. It's just a simple form that we created a while back ago.
Great, fantastic. Next question, can we use the AMA guides to rate the patient's whole person impairment? Guides are for workers' compensation. We used to use them to rate PI patients, but recently stopped because PI attorneys did not understand how to use them. The PI attorneys were often told that the guides' ratings were irrelevant to the case. So maybe we can have all of the panelists here kind of address that.
I would love to take that one.
John, you get that one.
So as a designated expert, I was pulled into trial on just this issue several times. And we would use Dr. Cronk's ligament studies, which come back with a whole person impairment, based off the guides, and present that in court. And to a jury, maybe they don't really quite get 15 whole person impairment or 20, whatever. But they understood, and the judge, so the defense tried to stop us from using the guides, and we got it in every time. It's a learned treatise. It's admissible. So I hear people say that, yeah, it's a work comp guide, but it's used in PI in California.
Yeah, it's not just so the AMA guides actually are utilized by Colossus. If you go on there on the CSC, the Computer Science Corporation website, they'll talk about Colossus and talk about how the AMA guides is what they utilize to determine the nomenclature of the injuries. So it's the 5th edition particularly is very, very valuable. I would say continue doing the ratings. Don't stop, because the PI attorneys don't necessarily have to understand it as much as Colossus, because Colossus understands when there's a rating, what that actually means, and that value goes into that assessment. So even if the attorney doesn't understand the AMA guides, it's still valuable in terms of, what the appropriate settlement value of the case should be.
The other thing, I'm going to weigh in on that just a little bit also, Doctor. The one thing that I say a lot in injury work is that confusion is contagious. Just don't catch it. So that attorney doesn't understand more than likely what an impairment guide is, because an impairment guide is an injury guide. And it's an injury guide that helps to say the consensus has said this injury causes this effect in that person's life. when it's explained that way. So when I started off my presentation, I said, hey, impairment, derangement, wound, lesion, they're all interchangeable. They mean the same thing. So most of the time that attorney does not understand that. And in my experience of teaching this, the attorney is thinking about a disability rating. A disability rating is far different than a impairment rating. However, there's not a disability rating system, which is what the work comp ratings are. There's not a disability rating system in the country that doesn't in some way use an impairment rating system, because the impairment is the underlying condition that causes the person to have a problem in the first place. Impairment means in their life. Disability means how does that thing, that derangement, that herniation, that cauda equina syndrome, that spinal fusion surgery, how does that thing affect their ability to earn a living? That's called disability. So most of the time, there's a lot of confusion as to even what the terms mean by the person that's trying to say, this doesn't mean anything. So you have to be not confused in any way, and you will be contagious to them. You're either buying their confusion or they're buying yours.
I just got a note from Daniel Shapiro saying that when I've used the impairment ratings, my settlements have quadrupled in value. So
that's pretty good.
Yes, yeah. No, but I mean, look, it's the way I see it, guys. We're not here to give the patients anymore. That's John Reardon's job, right? To get his clients as much as possible. I don't see that we are here to give the patients any more than what they deserve, but we don't want to shortchange them either, right? So, we're as physicians, we are the middle of the road. We're not applicant or defense. We should give what's proper and we should do what's appropriate. And I think that utilizing the tools, and if Colossus, which is a software that insurance companies use, values the AMA guides as a value driver, then it certainly should be done. That's how I see it. It's not.
Dr. Khan, I couldn't agree with you more, and I'm just going to chime in on that. The guides say that the doctor's job is to document in a manner that allows the patient access to any benefits they're entitled to. And also remember, doctors, a doctor's job, whether it's the chiropractor, the physical therapist, the pain management specialist, or the surgeon, the doctor's job is to reduce benefit need, not increase it. So if the doctor knocks out the condition and says the patient has no chronic pain, the patient has no activities of daily living problems, none, you've knocked out the benefit need. It's much different than the patient who fails conservative care, fails pain management care, goes into surgery, fails surgical care. Everyone failed all along the way. That patient has a super amount of benefit need. So each doctor's job, if the pain management specialist, if the chiropractor says, whoa, this isn't working for this patient, the pain management doctor's job is to go, wow, see the treatment I did? They don't need any other care now. That's the job of each level of doctor all along. The surgeon's job is to say, hey, everybody failed. Look what we did. Patient doesn't have a problem anymore. They still have the hardware. They still have the problem, but they don't have the symptoms or the hardship of the problem anymore. That's what each doctor's job is along the way. So, and I completely agree with you, Dr. Khan, because that's what we're doing. We have to document it really well so that the insurer or whoever else is going to determine benefits can do a much easier job of it.
Thank you so much. We are looking at approximately 3:16 right now. I know there's some questions that have not been answered. I've been told here that I should wrap this up at this point. Once again, we do have our follow-up seminar with Dr. Kevin Trin, Pain Management, and Dr. Alina Jaffe, neurosurgeon, next week on 6/4 at 2 p.m. So we would love it if we could join us for that. We will forward these questions to the specific individuals and the physicians that you wanted them answered by, so you can get those answered through email. So they will be addressed for sure. All of our panelists, thank you so much for being on with us. Thank you, Injury Institute. This was absolutely phenomenal and fantastic. Thank you for having me on with you. And that's about it. Thanks, everyone.
Anybody wants the slides, make sure, Shadi, I'll give them to you so that you can send
Absolutely. Please reach out to me. Thank you.
Thank you.